Namaste. This educational surgical video demonstrates surgical clipping of ruptured MC aneurysm and unplanned end-to-end anastomosis of STA with MCA. It is a step-by-step demonstration. For a glimpse, you can notice here a broad neck, large M1 MC aneurysm. This is the surgical anatomy. You can see the microscope view and even the endoscope view here. Because of the atherosclerotic calcification at the neck, clip was getting slipped down and anterior temporal artery, which was originating at the neck, was getting included in the clip. So this, you can see the clip is applied. This is the endoscopic view. The anterior temporal artery is in the clip because there is a calcification at the neck, which was, and in this ICG you can see that the anterior temporal artery is not filling and even the aneurysm. So we went ahead with STA MCA bypass in this case. So hence anterior temporal artery was divided and brought up in the sylvian fissure, and anastomosis with STA end-to-end fashion was done. Here you can see this was an unplanned bypass, but it can be executed if we know the skill of bypass. This, you can see the successful end-to-end anastomosis in this case. She was a 56-year-old female who presented with sudden onset of severe holocrine headache of 6 days with multiple episodes of vomiting. She was hypertensive but on regular treatment for the last 8 years. On examination, her GCS was E4 M6 V4. She was a little bit confused, that is 14/15, and there were no neurological deficits. In detail, the nature of the illness, the available model of treatment were discussed in detail with the patient and the relatives, and then patient was submitted for the angiogram study in detail, and then she was planned for surgery. So this is a CT angio. Here you can see the axial view. There is an wide neck aneurysm seen behind the clinoid. The AC and MC you can see arising from it. So there is a mild SH in the sylvian fissure. This is a large multiple aneurysm in the arising from the M1 segment of MCA. In this 3D reconstruction image, you can see this is IC bifurcation. The post bifurcation immediately after M1, the aneurysm is arising. It is quite large. The neck is wide, and you can see here the anterior temporal artery. It is seen arising from this is a beautiful anatomy, A1, M1, MC, IC, everything. So this is aneurysm, that is ICA, this is M1, this is IC bifurcation. And you can see the anterior temporal artery arising at the neck of the aneurysm here. So this is the anatomy. So we thought that simple clipping might suffice, but there was a surprise intraoperatively. So patient was positioned supine with the head in extension above the heart level and 15-degree turn to the opposite side. Then curvilinear incision exposed the wound, and we did a pericranial graft raised, and the muscles were raised, and the terminal craniotomy exposed the sylvian fissure. So this is a sylvian fissure. We can see the brain is quite full. There is an SH around the sylvian fissure. So I am just opening the distal part of the sylvian fissure here. As you know, the aneurysm is quite proximal. This is the M1. So just to relax the brain, I started dissecting from this side, and you can see there is an SH. Then I move forward. You can see the MCA is exposed to the sylvian fissure. There is SH and some part of hematoma. So that is the optic now, and this is optico-carotid cistern. So before I went to the bifurcation, I opened the arachnoid routine in all the cases so that the CSF gets released. So this is the proximal proximal sylvian fissure which is being exposed here. So we have to be careful that whenever we expose an aneurysm, the proximal part of the vessel of the aneurysm has to be exposed, because if it ruptures, we have to catch hold of the proximal surface, proximal part of the vessel for temporary clipping. So you can see here the fundus is buried into the frontal lobe. So that is a optic nerve there, and under that we can see the A1. So it is dissected off from the frontal lobe and the optic nerve. So I did a little bit of corticectomy on the surface, and we knew that the aneurysm had ruptured from the ventral and posterior part of the fundus. So this is aneurysm here. So this has to be quite slow, meticulous, so that aneurysm should not rupture and not applied any temporary clip at. So this is aneurysm here, and those are all the blood clots after SH. So I have applied this retractor for some time, and you can see there is a teeth there under my uh, dissector. So that is a clot I'm taking out, and ICA bifurcation is coming into view. So we are literally excavating the aneurysm from the frontal lobe and the blood clots around it. So here you can clearly see the bifurcation, that is A1, M1, and I'm using the beautiful QO endoscopic inspection tool by Zeiss. So this gives us a complete view. You can see the ICA beautiful bifurcation here, optic now, and that is the antetemporal artery originating there. That is the ATA is the antetemporal artery. So that is a clinoid. So this is a bifurcation, and this is the neck of the aneurysm, and that is the M1, which is distal to it. The beautiful bifurcation seen in the endoscopic inspection tool. So this gives us a complete idea of the wide-based neck, the origin of the antetemporal artery. So now it is completely exposed. I am ready to clip using a around 11 millimeter straight titanium Yasser gill aneurysm clip here. So you can see that antetemporal artery I have not exposed. So I'll just clip it, and I have not put any temporary clip here. So you can see the ICA is partially clipped in the blades, because when I aligned along the neck, the tip was pointed towards. So I have to readjust the clip so that the ICA, which is being included, is released from the clip. And then once it is done, I will turn the aneurysm on this side and dissect further to know the position of the antetemporal artery. So after this, the aneurysm is completely obliterated, the neck is obliterated, and aneurysm is not filling in this case. But I am doubtful about the antetemporal artery, which is quite big as I thought in the pre-op images, and even in the intra-op images here. You can see this is the tips using in endoscopic inspection tool. I see that the antetemporal artery is in the tips of the aneurysm clip blades. So I am dissecting further here. So that is the antetemporal artery being dissected from the fundus. So this manipulations I avoided in the beginning because that might rupture the fundus. So you can see that there is a ruptured teat of the aneurysm there, that is a ruptured part. For this reason, we avoided exposing this part before applying the clip. So I have applied the clip, so my neck is secured. So I can manipulate the fundus of the aneurysm, I can expose the complete neck, and then I can readjust my clip. So here you can see that at the neck there is an yellow atherosclerotic, probably a calcified plaque under my suction tip. That is the thing I am retracting. So that is avoiding for the clip to sit in the proper position. So this is a complete exposure, and I want to readjust so that I can save the antetemporal artery and completely occlude the aneurysm. So even with this upcurved, so that I use the upcurved so that I will avoid catch holding of the antetemporal artery. So even after this, you can see that antetemporal artery is coming into the blades of the clip. So this is what has happened. We need to know the anatomy of the antetemporal artery here. Most of the time we divide it to mobilize the antetemporal lobe in case of approaching basilar artery. But in this case, I felt it is quite big and I didn't want to sacrifice, though I'm on the right side. So I try to readjust the clip. You can see that I'm trying to readjust the clip, but the clip is not sitting at the neck, but it is slipping down because of that yellow atherosclerotic plaque, probably which is calcified. So still with this upcurved clip, the antetemporal artery is getting included. You can see here my problem that over that yellow part, the blades are slipping down. I'm not able to hold at this point because that is a calcified neck because of the atherosclerosis. Still with this upward clip, I will once again use the endoscopic inspection tool. Is quite beautiful, and still the ATA is in antetemporal artery is in the clip. So you can see that I initially felt that there is some part of the vessel which is patent, so probably it is filling. But once I used ICG, so in ICG that is a calcified, you can see that the aneurysm is completely obliterated. The ICA, M1, MC are seen, but antetemporal artery is completely ATA. You can see it is not filling. It is completely obliterated. It's a quite big vessel. So For this reason, only solution I had was end-to-end anastomosis. So in this case, what we did was I divided the antetemporal artery. I initially exposed and harvested the superior temporal artery branch here. So I'm keeping the dam, and I'll prepare the superior temporal artery. I'll dissect it off from all the adventitial tissue layer. Initially I measured the length so that it goes down into the ciliary fissure. So after that, once the vessel is prepared and denuded off from all the connective tissue and even the adventitia, so it's a good vessel and probably almost equal to the size of superior temporal artery, around 0.9 millimeter to 1 millimeter is the size of this vessel. So it is quite important to free this vessel from surrounding tissue, mainly adventitia, because that might prolapse into the suture line, and that is quite thrombogenic, and our anastomosis might fail. So I'll recheck again so that there is no thrombus in the lumen distal to the clip applied. So I'm okay with, and even I see that the vessel is not kinked by the muscle there. So I'm marking the surface so that the vessel should not get kinked once it is anastomosed. So the surface marking is quite important, and I have marked the surface with the ink here. So surface is marked, and here what I have to do is I have to divide the vessel. For that reason, I have to apply a small clip just at the origin of this antetemporal artery. So that is the origin, that is a calcified part, just distal to the calcium. There is some part of atherosclerosis extending to the vessel also. Even on this vessel, we have to mark the surface, because once it is divided and brought, we lose the surface orientation, and sometimes the vessel will twist and the anastomosis will fail. So antetemporal artery is divided now, and I am bringing it up into the sylvian fissure so that it will be easy for me to anastomose here rather than down into the deep medial part of the sylvian fissure. So that is the antetemporal artery, quite large one. So I am preparing for anastomosis. This is a dam which is kept over here. So there is one vessel that is arising distal to the division. You can see that there is a white streak, and that is the atherosclerotic calcified part which is extending in even into the origin of the antetemporal artery. So this is not a good site for anastomosis. So I just prepared this vessel. Transverse cutting we have to do. Herein you can see the lumen is okay, because if it is a calcified, the intima will separate, and that will cause once again thrombus, and even the sutures might get cut through. So after this, we did a transverse arteriotomy so that they are parallel to each other, and we can go ahead with the end-to-end anastomosis. So we are okay with the surface orientation here. So the end-to-end anastomosis is a reconstructive bypass between the transected ends of two arteries, and usually from an aneurysm's parent artery after the pathology has been excised. Like I have divided distal to the pathology, and there is some part of the calcified and atherosclerotic plaque which was extending to this antetemporal artery that have taken out completely. So this bypass reconnects or splices together arterial ends without introducing a donor artery or a new input like radial artery we are not using here, or a saphenous vein, and therefore it simply restores the origin blood flow here. So the end-to-end anastomosis is circular. You can see the transverse end, which gives it a third dimension that the end to side, neither the side to side bypasses lack. So the longitudinal arteriotomies and quadrangular fishmouthings associated with these anastomosis give them linearity that yields simple flat suture line in case of side to side and end to side. So whereas arterial transactions associated with this particular end-to-end anastomosis give it a circular with a vertical orientation that yields deeper and more complicated suture arcs. So it is quite difficult than compared to the side to side and end to side anastomosis. So I am here putting suture from one, like imagine that it is at 12 o'clock and 6 o'clock is the first. So then I have to suture from 12 to 6 and 6 to 12. So in this visualization, instrument position and maneuverability change with each step along the arc. So adjustments are required to bring the tissues to the top of the surgical field and to center the bites in suturing arc. So the arteries must be rotated back and forth to sieve the two suture lines, and the walls must be shifted and aligned with microforces for each bite. You can see here. So these ongoing tweaks make the end-to-end anastomosis bypass that requires more surgical fineness than other two. So the end-to-end anastomosis is successful only if all the pathology of the is excised, like what we did is atherosclerotic plaque we excised in the beginning. So because if something is remained, that comes in the suture line and that damages the anastomosis. Sometimes in this case we have got a quite long graft and even the antituber is mobilized. Otherwise, if the gap is too long and the arteries are under tension, knots cannot approximate the ends. So suture pull through the walls happen and the lumen collapse on itself and the arteries do not rotate. So that is difficult, but in this case it is quite easy. So this can complicate. So afferent and efferent arteries are sectioned transversely and we have seen here, and the aneurysm is like excised and that is completely separated and the vessel is brought up into the field. So the arterial, so you can see that I have put two sutures at 12 o'clock and 6 o'clock, and I am suturing on the dorsal surface. I have marked the dorsal surface with the marker so that the vessel are not rotated and they will not get kink. So as we saw, first is placed at 12 o'clock and 6 o'clock and we are suturing in between. So in this case, the shanks of the temporal clips can be rotated as I am doing here, so that I open the opposite side of surface of the arc here. So you can see that I have put around the sutures in this scenario, like end-to-end anastomosis are quite less compared to end to side or side to side. So hardly, if you imagine that for side to side or end to side, if you require a dozen of sutures, in this half a dozen of sutures are enough. So I use intermittent sutures in all the cases, and I prefer to go with intermittent rather than continuous. So in this you can see that the shanks of the aneurysm clip blades are sufficient to hold the rotated position, or sometimes you might have to keep the cottonoids to keep vessels in this position. You can see in the picture, so that how the vessels are brought in view. So yeah, so this continues with 3 more sutures. So to complete my complete suturing, so it is quite important to understand that it is anastomosis is a suturing technique that we all as a neurosurgeons practice routinely, from general surgeons to surgeons or any surgeon who does suturings. But in this case, it goes down to the highest zoom level and we have to get adjusted with the very small suture material like 10-0 in this case, and very small instruments and working at the highest zoom. So we have to zoom in, zoom out, zoom in, zoom out with each step, and cannot pull these suture materials and handle them roughly because they might cut through from the needle itself. So it's quite important to learn the art of anastomosis, so that in this scenario like unplanned anastomosis, it was absolutely not planned. But if I would not have learned this technique, so probably I had to accept either the inclusion and obliteration of the antetemporal artery, or I had to clip the neck above. So this completes my complete aneurysm here. So I'm anastomosis here. So I have released the distal clip first, and after that I will release the proximal, that is the STA clip actually. So this is supratemporal artery which is high flow, and yeah, it is quite beautiful to see that the anastomosis is functioning, the vessel is filling, and this is what we would love to see when we anastomose. And this is what you can see here, that there will be some part of the bleeding through the legs of the sutures and sometimes in between the suture lines. So hardly I have put around 7 to 8 sutures in this case, and I have completed this anastomosis. So it is there's a good pulsation, and after giving saline wash, absolutely there is no bleeding and the anastomosis is quite okay. So this completes our anastomosis. We have clipped the aneurysm. I have divided the antetemporal artery, brought into the Sylvian fissure, and I use something like this suction you saw that under the dam, so that all the blood will be sucked. So this is the widely opened Sylvian fissure, and that is the neck and the fundus of the aneurysm, and that is the ICA optic now there. So usually in larger aneurysms, we open the fundus of the aneurysm, so that sometimes if the neck is calcified, the clips may not approximate it properly. So for that reason, aneurysm might be filling. So in this case, you can see the aneurysm is not filling. It is very much atherosclerotic, and still with such a thick wall, it has ruptured. So this completes the complete clipping of the aneurysm. The neck is completely obliterated, and we have done the end-to-end anastomosis. You can beautifully see in this ICG, the neck is completely obliterated, the aneurysm not filling, ICA, M1, MCA, and even the antetemporal artery to Sta-Mca bypass is very well pulsating, and it is filling. So this is quite important for any surgeon to learn and be prepared for any vascular events in any cases of trauma or any surgeries like skull-face meningiomas and even CP angle surgeries or CVJ. Sometimes we might injure complex CVJs, we might injure the vertebral artery. So in this you can see that antetemporal artery and ST are quietly filling, that is the anastomotic site. Aneurysm is completely obliterated, and A1 MCA are completely clearly seen here, and there is no vasospasm, and there is no anticipated to be have a stroke in this case because it is completely filling. So this is another case that we did. It is a quite large giant aneurysm, and the vessels, distal vessels, were originated from the fundus of the aneurysm itself. So this definitely needs trapping, and the distal vessels have to be anastomosed. In this case, I did a first M4 to ST bypass, and then did clipping of this aneurysm, and then other anastomosis. This was one of the giant aneurysm, around 10.5 centimeter. It was coming out into the all the sinuses and even for the molar tooth, and it was quite large. So we trapped the aneurysm, and using a radial artery, we did a high flow bypass. So this is a high flow bypass. You can see the aneurysm is completely trapped. In the pre-op image you can see, and this is a post-op. Aneurysm is not seen, and radial artery is completely filling. So this is other case, a young lady who came with this large unruptured aneurysm, and it is quite large, arising from the cavernous IC, sinus ICA, and in this there was no ACOM, neither the PCOM to fill. This is a CT angio. You can see this is a completely filling large aneurysm in a young female arising from the cavernous ICA. So this is what you can see, the high flow radial artery bypass. This is anastomosis of the EC in the neck, and this is a radial artery coming up into the cranium. So that is the site of M4 to M, this radial artery to the M2 bypass. So this is the beautifully filling vessels, and aneurysm is not seen. We completed around 100 plus anastomosis and 600 plus aneurysms in the last 10 years. So this is a beautiful scan. The post-op image, you can see the aneurysm is not filling. There is a pre-op scan. You can see the aneurysm was hyperdense in this case, and there is a graft. Micro-anastomosis of intracranial arteries remains an important procedure which can save the patient's brain from ischemic complications by intentional or accidental occlusion or injury of the parent artery during intracranial aneurysm surgery or tumor surgery. So sometimes we leave a small bit of tumor around the vessels in the fear of injuring the vessels. So when you have mastered such techniques, you go ahead and resect because you can handle the complications if it happens. So sometimes the fear stops us from going further and achieving complete excision. So therefore I believe the future of bypass surgery looks bright. Vascular neurosurgery is tough, demands top-notch skills and training, and even with the endovascular treatment, it still teaches you the gutsy skill to handle the cerebral vessels in brain surgery and tackle vascular complications head-on. In this AI and robotic era, mastering microsurgical skills like microvascular anastomosis gives us that extra edge. It's the same suture technique we all know, but taken to the highest zoom level with the smallest vessels around 0.6 to 1 millimeters, very small instruments, and suture materials like Tangiro that we used in case, It is just a shift in mind and materials to the microzoom level, because we all do suturing as a surgeons. Mastering microvascular anastomosis boosts the confidence and skills to tackle the vascular complications, mainly in the skull-based surgeries like clonal meningioma, CP tumors, complex CVJ surgery, where sometimes we might injure the vertebral artery, get to spasm, we can handle that. And definitely in complex aneurysms like what we did, and definitely it has a significant role to play in myoma disease. Flow diverters are reducing the bypass use, but won't replace it entirely. Complex cases will still need bypass expertise. Low flow bypass like Sta-Mca will grow for distal aneurysms, mainly where we cannot use the flow diverters. And with this, the future of bypass surgery looks bright if the surgeon masters the technique, skills, anatomy, and attitude. Thank you.